Hey everyone, and welcome to this explainer. Today we're literally stepping into the shoes of a medical detective. We're tackling a seriously high-stakes case of water dysregulation. Specifically, how to decode and accurately diagnose diabetes insipidus, or DI. We're going to rely on a foolproof, step-by-step clinical algorithm pulled straight from our source texts. By the end of this, you'll have a rock-solid grasp of the exact diagnostic criteria, the critical thresholds, and the precise protocols you need to solve this clinical mystery without a shadow of a doubt. So let's get started.
Okay, let's dive right into this map of ours. First up, baseline diagnostic criteria. Second, interpreting the initial labs. Third, the osmolality zones. Fourth, water deprivation protocol. Fifth, reaching the endpoints. And finally, number 6, Peterson and final diagnosis.
Section 1. Baseline Diagnostic Criteria. Let's examine the scene of the crime. The very first clue we're looking for is dilute urine. In a typical DI case, that urine osmolality is strictly less than 300 milliosmoles per kilogram, and honestly, it usually hovers way down between 50 and 150. To put that into perspective, a normal average is somewhere between 500 and 800, with extreme normal ranges stretching from 50 all the way to 1400. But here is your first golden rule out. If you're seeing a urine osmolality greater than 800 milliosmoles per kilogram, you can completely rule out both DI and polydipsia. The kidneys are concentrating urine just fine, so your suspect is definitely hiding elsewhere.
Now, what's really interesting here is urine-specific gravity, or USG. It's a fantastic, super quick bedside test, but, it's just not quite as accurate as measuring osmolality because it gets heavily affected by the size of solute particles. In DI, USG is usually less than 1.003. But here's the warning you have to watch out for. Certain moieties that produce osmotic diuresis can actually falsely elevate the USG. It makes the urine look more concentrated than it really is, effectively masking the DI. So be on high alert if your patient has had large doses of mannitol, which we often see in head trauma, or high glucose from poorly controlled diabetes mellitus.
Moving on to the actual volume of the crime. Polyuria. Now, polyuria isn't just some vague feeling of paying too much, right? It has strict, age-dependent thresholds. For adults and kids age 2 and older, polyuria is defined as a urine output strictly greater than 50 milliliters per kilogram per 24 hours. For your standard 70-kilogram patient, that is more than 3.5 liters a day. But look closely at the pediatric numbers. At birth, for gestational DI, the threshold is a massive 150 milliliters per kilogram per 24 hours, and for infants up to age 2, it's greater than 100 to 110. I mean, that is an absolute mountain of wet diapers. You have to make sure you're using the right threshold for your patient's age.
Next up, we check the blood. For a DI diagnosis, the serum sodium must be greater than 135 millimoles per liter, meaning it's either normal or above normal. Why? Because the classic hallmark sign of diabetes insipidus is the absolute stubborn inability of the kidneys to concentrate urine to greater than 300 milliosmoles per kilogram, even when the patient is visibly clinically dehydrated. They're constantly losing free water, which naturally concentrates the sodium right there in the blood. Before we close the book on baseline criteria, there's an often missed accomplice we need to check for: adrenal function. Normal adrenal function is strictly required to diagnose DI. Why is that? Well, DI literally cannot occur in primary adrenal insufficiency. A baseline amount of mineralocorticoid activity is physically required for the kidney to even make free water in the first place. Because of this, giving a patient steroids to correct adrenal insufficiency might actually unmask an underlying DI that was just hiding out of sight the whole time.
Section 2. Interpreting the initial labs.
Let's start with our rapid rule-outs. If there's an absence of polyuria, boom, you can immediately rule out both DI and psychogenic polydipsia, which is pathological water drinking. Furthermore, like we touched on earlier, if the patient does have polyuria but their urine osmolality is greater than 800 milliosmoles per kilogram, that also definitively rules out both DI and polydipsia. The kidney is clearly doing its job by concentrating the urine. On the flip side, how do we spot the imposter, primary or psychogenic polydipsia? Well, this is diagnosed when your patient presents with polyuria, but their serum sodium is less than 135, meaning it's normal or low normal, and their plasma osmolality is less than or equal to 280. In this scenario, the excessive water drinking is just diluting everything down, suppressing the natural concentration of the blood.
Section 3. The osmolarity zones.
And this brilliantly illustrates the diagnostic power of just plotting our data points out. If your patient's data point lands on the left side of the spectrum, showing a low serum osmolality of 280 or less, it usually points straight to psychogenic polydipsia. But
If your point lands all the way on the right side, showing high serum osmolality alongside that dilute urine, the diagnosis of DI is firmly established. Once you hit that high point, absolutely no further diagnostic testing to establish the diagnosis is required. Now, if you're securely in that high serum osmolality DI zone, further testing is really only needed if you want to differentiate central from nephrogenic DI. You can do that by giving 5 units of subcutaneous aqueous pitocin to see if urine osmolality doubles. But what if the data point falls right in that murky, normal middle zone, or just kind of vacillates around the border? Well, that's when we're forced to move to our most rigorous test to see if the patient can concentrate their urine under pressure, the supervised water deprivation test.
Section 4. Water Deprivation Protocol.
All right, before we list the steps, we absolutely have to address this critical warning directly from the source texts. Caution. You must perform this test only under incredibly close supervision. In patients with true DI, depriving them of water can lead to rapid and potentially fatal dehydration. The stakes here are incredibly high, and it's exactly why this protocol is so strict.
So here is the exact step-by-step water deprivation protocol. Step 1. Stop all IVs immediately and make the patient strictly NPO, meaning nothing by mouth whatsoever. Step 2. You must check their urine osmolality every single hour. And step 3. You have to check the patient's weight every single hour. This high-frequency hourly monitoring is your absolute safety net against that fatal dehydration we just talked about. Section 5. Reaching the endpoints.
You literally have to stop the test immediately if just one of these 4 events occurs. First, if a normal response occurs. A normal response is when urine output actually decreases and urine osmolality naturally rises to somewhere between 600 and 850. If this happens, it proves primary polydipsia, and you stop the test right then and there. Second, stop if 6 to 8 hours lapse entirely. Third, stop if the urine osmolality plateaus, meaning it changes by less than 30 milliosmoles across 3 consecutive hours. And finally, for the patient's safety, you pull the plug on the test immediately if the patient loses 3% of their total body weight.
Section 6. Pitocin and final diagnosis.
So the crucial point is this. We force the kidneys to confess by giving exogenous ADH, specifically 5 units of aqueous pitocin given subcutaneously. In a normal system, this synthetic hormone should command the kidneys to hold on to water, bumping the urine osmolality to greater than 300. We just need to wait and see exactly how our patient's kidneys react to this command.
But the monitoring isn't quite over yet. After injecting the pitocin, you need to check the urine osmolality exactly 30 minutes later and then again 60 minutes later. The ultimate calculation here is to take the highest urine osmolality recorded after the pitocin injection and compare it to the osmolality you took right before the injection.
That final comparison gives us the delta, or the change in urinary osmolality. If the increase is less than 5%, the interpretation is totally normal. If the osmolality jumps anywhere from 6% to 67%, it firmly indicates a partial ADH deficiency. And if administering that ADH causes a massive increase of greater than 67% in urinary osmolality, well, you're looking at a severe ADH deficiency. The numbers just don't lie, and they point directly to your final diagnosis.
And there you have it. We've walked step by step through the rules, the labs, the zones, and the high-stakes deprivation test without skipping a single vital metric from our sources. So, by mastering every specific number and safety endpoint we've covered today, how are you going to apply this foolproof clinical algorithm to safely and accurately catch the true culprit in your very next polyuria case? Keep these numbers close, trust the algorithm, and keep learning. Thanks so much for joining me on this explainer.